Very good. All right, so you guys want to get going?
30 seconds, we'll on the air. We'll be on air.
All right, perfect.
I mean, if Dr. Q and Dr. Hakeem and Juan Pablo are in agreement, Diogo, why don't you put that slide that you have for Dr. Hakeem and his team? It would be a pleasure just to, introduce the team that we are, very happy and proud to have today with us. Dr. Fernando Hakeem Dakar from Colombia and from the Hakeem family, as you see here, which definitely a family of innovators. Solomon Hakeem is a worldwide, person, and definitely one of the families that make us all very proud, not only neurosurgery, but from more Latin American roots, with all the development with normal pressure hydrocephalus and VP shunts involves. But Fernando Hakeem himself is also, a fantastic person and neurosurgeon. You see, chairman of neurological surgery at the Hospital Universitario Fundación Santa Fe de Bogotá. He is the professor of neurosurgery at the Universidad de los Andes, an associate professor at Universidad del Bosque, one of the top doctors in Colombia. I would say certainly not only in 2018, but in tons of years. Fernando is a fantastic person, good friends, has projects with Dr. Quinones that I know of. And we are very proud to have himself and his entire team speaking directly from Bogotà and discussing some cases with our team and with the planet today here through Mayo Clinic. So Dr. Hakeem and team, Juan Pablo, welcome everybody on behalf of our team here at Mayo Clinic in Florida. And we're looking forward. We've been looking forward for this for a while now, and it's exciting to have you guys here.
Good morning, Dr. Q. Good morning, JP. Good morning, Andrea, that I'm seeing. I know. I spoke also to Ravi, that he's going to be probably connected. Well, once again.
Yes, I'm
Dr.
here.
Q.
Good morning,
Ravi. Good morning, Ravi. Once again, thank you for this opportunity. In my way coming here to the hospital today, I remember some words that one day my father told me. He said, definitely in Spanish, he said, uno vale por sus amigos. You're worth more according to the friends that you have. That definitely is something that when life passes, you notice that is really a fact. So we consider you, all of you, our neurosurgeons, but we consider you friends, but we consider you our close friends, and you've helped us a lot in our formation as neurosurgeons. You can't imagine, I was just telling JP that we did some cases this week with Diego and all our team, with Juan Fernando, Juan Armando, that it remembers us a couple of months ago being in the lab with you guys in the Mayo Clinic. It helped us a lot. So the cases that we're going to present to you this morning are definitely cases that make you see the neurosurgery as it is. Remember that sometimes we have always in our hands our patients, and a simple decision of seconds can make you save a life or save the quality of life of a person. And these cases that we're going to present to you will show you that we decide to do something in 30 seconds probably, and that changed the life of these patients. So I'm going to give my word to Diego, and here's all our team here, all with the residents, interns, students. It's just our family here now. And Juan Pablo Leal, that he's not with us, he's in Phoenix, in Barrow. So he's gonna be talking from there. And I'm gonna give the microphone to Diego Gomez, our colleague.
Okay, thank you, Dr. Hakeem, and thank you, everybody. It's a pleasure to be in this meeting with the Mayo Clinic group, and it's an honor for our institution to show you a part of our work. Thank you very much, Dr. Q and JP, for the invitation and Robbie talk and the incredible team in Jacksonville. So we selected this case because beyond the fact that it's an interesting pathology, it's a case that taught us a lot. And once again, shows that teamwork is essential in our profession. So I want to give now, and I want to introduce to Isabella, which is our internship, and she's doing now her internship. So she has been working a lot in this case. So let's go, Isabel.
Yeah.
Good morning, everybody. Can you hear me? Can you guys hear me?
We hear you perfectly.
And are you watching the screen?
Yes, we got a beautiful screen and a beautiful building.
Oh, thank you. First of all, good morning to everyone. I would like to thank Dr. Quiñones for this opportunity. For us, it's amazing. Keeping us together, building bridges, and being able to share our experience with the rest of the world. My name is Juan Pablo Leal, and I'm PI4, resident of neurosurgery at the Bosque University and Santa Fe, Fundación Santa Fe. I would like to highlight that we've been certified by the Joint Commission International since 2017. It's an honor for us. We've been the first one certified for this, and so far the only one. This is our amazing crew. Just a quick review that we are always working together, but behind the head of our chairman of the neurosurgery department, Dr. Fernando Hakim. Not just the neurosurgeons as well. We also, on the good things that happen to our patients is because our amazing team is composed by our neuroanesthesiologists, interventional radiology, neuroradiology, neurointensivists, neuropathologists, and all of us working together to get a better results in our patient outcomes. So here, I would like to highlight again Maria Camila Pedraza. She was very involved with the case, so it's important to mention. And Isabella, as Diego Gomez said, I would like to thank her because she's the one who made this presentation possible, working hand by hand with us, with me. She's in her last semester of med school. She wants to become a neurosurgeon. I just wanted to tell her that she's doing right. She's going in the right way. Well, this is our clinical case. Our main attending, Dr. Diego Gomez and Dr. Fernando Hakim, and our neurointerventional radiology is Juan Andres Mejia. I would like to start giving the word to Isabella. She's going to start our case.
Okay, so this is a 40-year-old patient, female patient from Colombia. She had a history of epilepsy since childhood, which was now controlled, and she was diagnosed 2 years ago with an unruptured AVM. Otherwise, she had no other history of any kind of pathology, no history of alcohol consumption or of smoking. Her physical exam was completely unremarkable. She had normal augmentation. She had no language disturbances and no cranial nerve deficit and no motor disruptions. So we decided to make an MRI, and this is what we found.
This is her MRI that the first time that she came to our clinics. On the left side on the screen, I'm showing you a T2 actual sequence in 5mm slice, showing the hypotenuse lesion on the left frontoparietal side of her brain, that is localized in the motor and sensory area. On the right side on the screen, we can see as well that the imaging is related with their characteristics are most consistent with an AVM with a fluid void image. So being this, we measure the our lesion, and it's about 3 to 6 centimeters wide. So we perform an angiography, and I just want to highlight that this AVM had 5 different feeding arteries. One who comes from the left ACA, one from the left PCA, The another one from the meningeal arteries, one who comes from the other side to the right external cerebral artery, then posterior meningeal artery who comes from the vertebral artery, and one from the left external middle external cerebral artery is the middle meningeal one. So finally, for make a correct classification of the AVM, we also perform is also showing our venous drainage, that it was just superficial, no deep venous drainage. So far, what do we have? Do we have a 40-year female with headache, with seizure, but they were controlled, 3 to 6 centimeters on the left AVM, is localized in the motor and sensory area with superficial drainage only, no neurological deficit, no previous bleeding, and is not located in the brainstem. So we did our classification, especially Martin one, and it was a grade 3. So we also decide to make a complementary grading scale. So we use Malcolm Lawton and Young scale. So they were the score were 3. So if you combine 2 of them, the score is going to be 6. So if we stratify the 6, it drives us into a low to moderate risk. So for make our procedure or our thinking possible, we decide to keep doing a supplementary studies because the localization of this injury. So we did a tractography that is showing us right here a little decrease of the left side of the corticospinal tract with a little bit of displacement medially and laterally and a little bit anteriorly from the lesion. So we also perform, because the localization of the lesion, and functional MRI. On the left side on the screen, you can see how the lesion is bordering the primary motor and sensory area. And you can see it's displacing a little bit anteriorly. So on the right side, even though it's a right-handed patient, we found the activation area is predominantly in the right side hemisphere. So for us, it was like perfect, because where Wernicke area, it was only activated on the right side, even though it's a right-handed patient. So with all this data, patient wishes and a multidisciplinary board decision, we decide to go on and treat her. But here I would like to give the word to our neurointerventional radiology, Dr. Juan Andres Mejia. So why or which one could be our first strategy for make a treatment in the 5-feeding artery AVM?
Juan, do you hear me? Hello, everybody. I don't know if you hear me.
Yes, we hear you well. Juan.
Great. I want to say hi to everyone in Colombia, in the Mayo Clinic group. Professor Quiñones, we admire you a lot as well from the radiology point of view. Anyway, with this, in this case, we wanted to have step-by-step procedure. We decided to try in 2 different embolizations previously to surgical management, try to embolize as much as we could, especially those major feeders coming from the MCA and the ACA, as well as the feeders that came from the middle meningeal artery. So Juan, you can show us what's the continuous process, and afterwards we can discuss a little bit more.
Okay, then, so we put together our teamwork and we decided, as Dr. Mejia said, 2 endovascular stages, and then we perform surgery. So in the first vascular stage, it was made in 14th of February 2022. I would like to tell you to everyone to pay attention to the dates, because it's gonna be a case that is gonna drive us day by day. So that's important, how we have to deal with this day by day. So first, we did our first endovascular stage, taking down the left middle meningeal artery. So as you can see in the result of the first endovascular therapy. Then the second endovascular stage was made the 16th of February. So in this one, we tried to close the main ACA and ECA feeding arteries, but also we tried to do a small and distal pericardioidal occlusion, but it wasn't possible. It was really hard to get into the small feeding arteries that come from the ACA. So at the end, we have around 70 to 80% of the AVN was occluded, but that's what we thought. That's what we were thinking about how we're gonna get it done. So then after the endovascular therapy, the patient woke up with no neurological deficit, with a slight of headache, but then surgery was performed as we planned. I would like to take a moment to show you this picture because we fuse and integrate our conventional angiography, the picture that we have in the left and the right side on the screen, with our microscope, our navigation. So the patient was taken to surgery under general anesthesia. We put her in a supine position with a cephalic flexion of the head, 5 to 10 degrees to the right side to get a better exposure of the paramedian left craniotomy. We did all of this but under neuronavigation guidance. So we decided to integrate tactography on the microscope. Thanks to that, we got augmented reality. Also was possible to make this with under fluorescence guidance. And this is a safety ways to perform surgery, as you can see. Our microsurgical resection started for the remaining feeding arteries at the edge of the AVN. All the nidus was completed resected. Our surgery was with no complication, and the patient woke up fine, just with a little bit of hemorrhagic in her right side, as we expected because of the localization of the surgery. So the total OR time was 5 hours. We put her in the ICU. The patient, as I said, with a mild right hemorrhagic, but no motor deficit. So as I said, you have to stay focused on the dates because we did the first CT scan at the 17th of February, and that's what we hit. That's what we have here. And let me show you. In this CT scan, we thought that everything was good with a little bit of pneumocephalus, a little patch of hypodense and hyperdense around the surgical area. What so far we thought that was normal. It's not a bad CT scan. Actually, it's pretty good after 2 different stages of endovascular therapy and 1 big surgery. But the things start to get weird. So the very first day, the patient, with no reason, she had a huge neck swelling on the left side of her neck. So in the ICU, this was suggesting maybe it was an hematoma. So we performed an ultrasound, a bedside ultrasound. I said, okay, this looked like a hematoma. So we took her right away to the angio to see what was going on. So in the angio.
Juan Pablo.
Yes, Dr. Quiñones.
Juan Pablo, will you do us a favor? I mean, the case was so beautiful, but before you leave, can you go back to that video of the actual surgery? It was just so beautiful, so elegant. Maybe I can have Robbie just make a comment, or Dr. Miller, who are right here, just so beautiful way. And I also want to take a picture of it to put it on social media right now, to be honest with you, that combination of both. But Robbie, you want to comment about this? Look at what is going on right here. I mean, first, it's a daunting case. You know, second, you saw the beautiful workup. Now we're here in the operating room. They're clearly using different technologies, techniques, media platforms, and to be able to fuse and gain more knowledge of not only the anatomy, but how to attack the surgery. You know, Juan Pablo is very humble with Fernando and the whole team, but these are extraordinarily complex. Can you care to comment, Robbie, right here?
Dr. Quiñones, you let me know where do you want me to pause it?
You just keep it going right here, you know, or Dave, maybe Robbie is disconnected or something. Maybe I'll take it to you, Fernando. I'm not quite sure where my team is right here. I see them here, but they may have difficult disconnection.
We're here. Unfortunately, I had to go talk to my chair for a minute, so I had to pop out for 30 seconds. So I lost what you asked, Dr. Q.
No, that's
I mean,
okay. I'm going to be with the Fernando. Fernando, tell us a little bit about the technology that was used right here.
Yeah.
Hi, Dr. Hugh.
Maybe-
Just to give you a comment on all the audience, it's about, in this case, after two embolization, it's very, very important to know exactly where is the artery that is coming to the malformation. So this is very useful because we can use the conventional LAS angiography and to fuse with the neuronavigation to know exactly where is coming the artery. So in this case, the technology can be very useful as we can see here. So that's it. I think very useful in surgery, and we can use as well the tractography as we see in the images, little big back to our lesion. So we are in the very, very hard area. So the technology absolutely makes the difference.
Yeah.
And so
Yeah,
maybe for the audience, if you can tell what are these platforms? So you have everything integrated in the microscope. You have the tractography, arteries, veins. Do you have depth, also as you're looking? Because I believe we're looking at a 2D image, but I take it when you are in the microscope, you may have actually depth and perception of these structures.
Yeah. You can see the augmented reality, like the 3D. You can see like where all the malformation is, and you can see the cortical spinal tract. It once in a while it comes on the left side of the screen, so definitely that you can't go in that way. So it gives you a lot of.
That's what I thought.
Yes, and in this case, in the microscope, the focus and the depth will works as a reference in the neuronavigation. So you can change and you can see all the structures back in the malformation. So it's very, very useful because it's not 2D images, it's the 3D, and you can move around the microscope and you will see all the structures around. If you put and you draw the eye, you can go to the eye and you will see on the surgery.
Beautiful. I was fascinated, obviously. Normally, we consider, and Ravi's done a few of these beautiful cases with the patient awake. It makes it challenging, of course, but I don't think Ravi has used this technology to be able to know exactly where the cortical spinal tracts are. We have the navigation system and they can be registered right there. But what I see right here is that you have it live as you're doing the surgery, integrated augmented reality in the microscope, which is a very powerful platform. So congratulations, beautiful work. I just wanted to spend an extra minute because, it just, when you see cases like this and when you have been in this battle zone, you recognize the complexity, the elegance, and I want to make sure that people took a minute to appreciate that. Thank you. Thank you, Juan Pablo and everybody.
No, I agree. I think this is wonderful work. The navigation system, we don't have that system, Dr. Q, but it is.
I don't know why you guys are so pessimistic about the system. Let's keep going with your comments, but we'll talk about the system. Keep going, Dave.
Okay, then, well, it took us like 5 hours, the surgery. We put him in the ICU, and as I said, the physical exam was for the right hemihypostasia, but no motor deficit. So we ruled out the first CT scan, as I was showing you before. It was a really good CT scan post-op. So you can see a little bit of pneumocephalus, as I said before, but a little bit. If you can see here, I'm just gonna pause it here to show you a little bit of small patches of hyperdensity, but maybe so far it was usual for this. So the neck swelling was huge. So we decided to make an angio-CT because of that. So in the angio-CT, the findings were consistent with edema that was involved in the superficial, as you can see here, and the deep facial tissue, fat tissue over her left side of her neck. It was extending all the way to the retropharyngeal and parapharyngeal side. if you can see, is pushing to the right side. The airway is like getting close in the airway. So far, it wasn't an hematoma, but the same day at night, it was like 6 to 1 a.m. in the morning, the patient went worse. She was struggling with the breathing. She was having problems with her mouth opening. She went hypoxic. So we had to put her again to reintubation. So we decided, okay, what was coming on? That we have no idea what happened. So we decided to make an angiography, maybe to rule out different kind of pathology, maybe a cervical fistula or something like that. Well, we didn't knew so far. But surprise for us, none of this was on it. Actually, the complete AVM resection, as you can see here, it was made. So we were like, okay, there's nothing about that. Maybe it was just an edema. It was considered as an angioedema after the surgery. And we searched in literature and we didn't find something like it was extremely directly connected with the AVM or endovascular treatment for a brain lesion and a neck angioedema. We never see that before. So it was treated like that, and our patient was ready for extubation at the very next day. If you can see, the 20th of February. That's why I would like to highlight a lot about the dates. And after that, she woke up with no motor deficit. So okay, we're getting better. But then new onset of right hemiparesis appears the next day. So we're okay. What's happening? So we have to make one CT scan after that. And for price for us, the findings were compatible with an ACA territory infarct. And you can see here the small patches of hyperdensity. Now we consider this as a possible ischemic hemorrhage and focus around the malformation. So we rule out that at the same time we see this, we saw this problem. So the patient was already in the CT scan because of this. So we decided to run an angiogram at the same time. So what we are seeing here is like a cutoff of the pericardial artery segment. Our team, neuroradiology group, and everybody was so, okay, maybe this is an ACA acute ischemic lesion. So now I will have to start thinking fast to make the right time and the right decision. But I don't know if Dr. Juan Andres Mejia have a word for this, about these findings in the angio-CT.
Yes, Juan, thank you. It's very important that we have to follow up very closely these patients after such a big embolization and after, of course, resection, a surgical resection of the AVM, because of course all these arteries are going to begin to have a slow flow, and probably they're going to have a retrograde thrombotic process. So that's what we think that could happen in this ACA artery here, where she wasn't with any symptoms, and afterwards she developed this sudden hemiparesis because we're having a progressive proximal thrombotic process that definitely having an ischemic stroke in this patient. So it's very unfortunate that after all this process we have this, but anyway, we have to consider a lot of things in these cases because, for instance, we have to consider if we do any endovascular procedure after like thrombectomy. In this case, of course, it's absolutely forbidden to use any thrombolytic therapy. We need to use augmentation therapy, raise up the blood pressure, and of course we can have a rebleed in these cases. So those are cases that are very difficult, and we have to analyze a lot in this special feature.
So as Dr. Mejia said, she was not a thrombectomy candidate, not even for thrombolysis, because the huge surgery and the huge two endovascular procedures that we did. So we put her in a hemodynamic augmentation and look at the date. It's 22, so it's 2 days after that. But she just had right side hemiparesis. But the very next day, her Glasgow Coma scale went down to 11, and the right hemiparesis got worse, all the way 105. So we decided to 2 to 3 days after rule another CT scans. So this one was the one that we saw, that we thought, okay, this is worse than we thought. Progression of the lesion, worsening the edema, midline shift. It was more than 5 millimeters with a closing, with a lot of pressure and closing in the basal cisterns. So I would like to stop here and to make you make any comments that you have. I don't know if Dr. Gomez wants to highlight something about this.
Yes, Juan Pablo. I just want to, I mean, at this point, the patient, which is getting worse every day, and with this CT scan, I mean, now we comment with Dr. Hakim that now we are laughing and we are happy to be with you. But at that point, and I'm sure every surgeon has this feeling in this situation, is what to do, what is going on. Now it's a nightmare. So what to do at that point? I don't know if someone else wants to give you any comment, or what is next? What is your opinion? What is the next step to save the patient?
What was the timing between the embolization, interval of time between the embolization and the surgery?
The first, after 72 hours from the first endovascular stage. So we did endovascular stage one day, the very next day, after 48 hours, we did the second stage. And after 72 hours since the first one, we did the surgery.
Okay. You know, I mean, my comments are the following. I think in terms of indications for treatment of AVM, it's the most confusing topic that I personally have seen in neurosurgery, especially after the Aruba. Why we treat and when we treat and how should we treat are the three questions I think our society is the most confused about. So latest I've seen a report coming within the JNIS about the increasing incidence of ruptured aneurysm since the Aruba. Within the last few years, and I have seen it personally, I'm seeing more symptomatic patients from AVM than ever before, because it has been several years that we have not treated those AVMs. So I think we now know less about them, and they're bleeding more. Definitely hyperperfusion is a big consideration for those AVMs. What I learned personally, and you have here some hemorrhagic conversion and you have some edema. I used to keep my patients normotensive. Now I go hypotensive on them in the post-op period, because I have been hunted down in few cases that even with a blood pressure 140, 150, I have one patient in her records, once the pressure was 150 to 160, and the next thing she's calling the nurse and she said, I want doctor talk here. Unfortunately, she's not with us from a bleeding around day 4 or 5 with a systolic pressure between 150 and 160. So I'm pushing them hypotensive, and there is a report from Toronto talking about hypoperfusion and lowering blood pressure. Additional morbidity is something you want to consider with every treatment you do, and that's why morbidity for those AVM is so high, because added up, I mean, an embolization, an OR, an embolization, just every procedure has its morbidity. So that's why I try to simplify treatment for those cases nowadays. I saw you guys started with embolization of the middle meningeal, and you have beautiful penetration in the nidus, and that's wonderful. I tend to embolize the deep feeders instead of the superficial, because the superficial ones are easy for me in surgery to get through, even though not for this one, because most of them are coming from the middle meningeal, and you say, well, how am I going to open the bone? When I'm opening the bone on those cases, I try to stay outside I don't have a problem taking the bone off, but opening the dura is a big deal. Most of those scary vessels in the bone, they detach easily from the bone. But Chris Ogilvy, my friend, he put a paper about staged craniotomy on those. So instead of taking the piece of bone in one piece, I mean, take it in multiple pieces if you're concerned about those things. And I have done it in a few cases. Time for surgery after embolization. We used to book the OR same day with one faculty in my training, and that's how I kind of been on my toes for those cases. But they're so rare nowadays that, I mean, honestly, we rarely do an AVM case, just because the nature of the Aruba after, but especially related to occlusion of the venous outflow after endovascular, be ready to take the patient to the OR because sometimes your onyx deeply penetrate, occludes the outflow, and you're gonna deal with the bleeding. So take those patients. So minimize the time between your endovascular and surgery as much as possible, unless you're planning for staged embolization that's safe. So you can stage it, and I don't know the risk, because if you stage it slowly, you reduce the flow and the whole brain will adjust to that small change. And then you take it again for smaller embolization, the whole brain. I tend to feel like the more we do acutely on those cases, the higher the risk, because you change so many things to such a big flow. So if you do the changes more progressively and suddenly and slowly, the brain might tolerate it better. Neck swelling, I don't know how to put it together. You know, angioedema, I don't know. But to my understanding, it should be like more of a both sides. Was there any hematoma in the neck or just no hematoma? You guys showed the CT, but I couldn't tell.
No, there was no hematoma.
No hematoma.
No hematoma at all.
Yeah. Weird things after endovascular I have come across. Sometimes our endovascular devices, I had a case with multiple brain enhancing lesions, and I dig deep and deep and deep. I couldn't find anything to explain it more than smaller pieces of the endovascular devices. If you're rough on those, if you have not hydrated them, they're hydrocoated. And there is some reports of material showering in the brain and giving some weird reactions. And definitely, this is recorded in the literature multiple times. I have seen one patient, it was not my patient, but came as another patient. Dr. Quinones and Dr. Miller made some mention about the integrating this virtual reality on your microscope. It's a great feature. I think we have it, to be honest, at Mayo. I have used it years ago for some tumor or lesions. I think it definitely adds up to keep you cognizant of where your lesion is. And it's a beautiful addition to your case, especially when you integrate the motor. That's the big value. So all the time when you're rotating your microscope, you have it in your mind and keeps you up to speed. I'm using virtual reality on those cases. I started getting a 3D angiogram, and I look at all this with virtual reality pre-op to kind of figure the AVM, the feeders, and it has been helpful to me. I've used it in some cases. I had an aneurysm. I was looking into reaching to the other side, and on the virtual reality before surgery, I realized that the aneurysm on the other side is hidden behind the pre-com, and I'm like, you know what? I'm not going to do it. And I think virtual reality upfront adds up because it just makes us more ready for the anatomy and to answer the questions ahead of time. So you plan your surgery instead of let me see what I see during surgery. So it's a great addition. For AVM, there is an entity with hypervascular network around the AVM. And this entity, I've dealt with it several times. You have the nidus of the AVM, but unfortunately, you have a network of vessels around it, feeding it, and it's mingled with the brain. And that area, you just can't go after it because it's not the AVM. And if you take it out, just like this case, you're against the motor strip. So you have to be very strict going down. So that's difficult. I like what I changed when Dr. Quinones came to our practice, like the awake component being mapped much more aggressively with the neurology team, people with us in the OR proactively instead of me just being a surgeon using my bottom line. So to grow your team and invest in neurology to help you in the OR. with testing and more kind of those things. Beautiful case. Unfortunately, AVM have tough outcome, and I don't know how to explain this ACA occlusion. You know, if it is certainly possible that during surgery, pulling, pushing, or something, but definitely have massive vein edema and some component of a hemorrhagic conversion in this case. So for the sake of time, I'm not going to speak for hours, but this is my summary of this, of the comment.
Dr. Tuck, I want to say something regarding what you said before. First of all, I agree completely what you said about Aruba study. We're having much more ruptured and symptomatic cases of non-treated AVMs. And in this particular case, I think like being very critical from the endovascular point of view, I think we should try, we had to stuck to the plan. I mean, we were like very, okay, let's do 2 previous embolizations, but probably we should have been a little bit more making a progressive occlusion, probably with 1 or 2 more embolizations previously to the surgery, and maybe ensure that, for instance, those residual afferences from the anterior and posterior side of the AVM should be occluded, and maybe we would have a better result making more endovascular embolizations previously to the surgical management. I don't know, probably that's my big critic about the endovascular point of view in this case.
No, I you know, listen, it's David Miller. I'm one of the interventional guys here at Mayo. I think your decision to treat was fine. Your approach was really wonderful, and your technical expertise is clear. These things happen. I remember, as Dr. Talk mentioned so much, we just don't know. There's no, and I don't think there is a formula for when you go back and treat and how you stage these things. We all have stories. We all have, you know, numbers of cases in which we did it one way and it worked out great, and then we do it the same way again and it doesn't. I remember back when I was in Emory in Atlanta, we took a woman and we did probably 5 or 6 pedicles, a large AVM. And similarly, we got a very good endovascular result with a good penetration of the nidus. And we said, okay, back in those days, we waited 3-4 weeks, let things settle down, let the flow change, and then come back to either finish a couple more pedicles or go to surgery. And we waited and we said, okay, we're going to wait, 30 days or 28 days, whatever. We were bringing the patient back. She was perfectly fine, neurologically intact. And when she came in for her pre-op labs on day like 27, she bled, and we just sat there and said, geez, if we'd have gone, a day earlier or a week earlier, we would have avoided this, but we didn't know how, she was fine. These things have lives of their own. And I think you're very, I appreciate very much your presenting this case, because many people won't. This is a difficult case in which, technically things went extremely well. Some of this is unexplainable, but
that's the idea,
I don't think you can criticize yourself.
Yeah, that's the idea for showing this case. And the matter of time with this awful CT scan that I just showed you. So we decided to make a decompressive craniectomy in this 40-year-old patient because her Glasgow coma scale went down to 11 from one day to another, and she was already on hemodynamic augmentation. So we also put at PTiO2 monitoring. So we put her to the neuroprotection measures. All our protection measures were guided by sedation with the RAS scale, 30 degrees head positioning, as always for us, 3 daily transcranial Doppler list. We keep doing the hemodynamic augmentation, and we was doing it before. And the PTiO2 measurement, the NIRS, brain metabolism every 8 hours. On the right side on the screen, as you can see, we have all these tools in our ICU department for trying to monitoring the patient to get better outcomes. So 3 days after the procedure, we rule out another CT scan, and considerable improvement in the reduction of the swelling, as you can see here. If you make if you compare to these two CT scans, you can see a huge difference between both of them. And the swelling is taking place at the site of the craniectomy. We still have a lot of focus on small patches of hemorrhage, but the patient is still under -5 on the RASS scale. So between the 3rd day to the 14th day, the PTO2 went better, for we were able, and the ICP went better, so we were able to take it out. Our transcranial Doppler that we performed three daily, so we took it out, we stopped doing it. We woke up the patient, her Glasgow Coma scale was 15 after a couple of days, so we went like lucky, I think. And our ICU guys were amazing doing their job. But she woke up with right hemiplasia to the day 14. So the next day, after she's been in Glasgow Coma scale 15, so we did a new CT scan, and she was doing great, but like really great after that. So we decide 15 days after the craniectomy, with a physical exam with 205 hemiparesis, and she still had a little bit of a hemiplegia, we decide to discharge the patient.
What a beautiful, those videos are so powerful, you know, to see that. Thank you for sharing. I'm sorry, keep going. I just wanted to comment that.
No, Dr. Q is perfect.
Amazing.
Wanted to show you the final CT scan that you can see here, Dr. Q. I mean, we did a cranioplasty, all the ischemic territories. It wasn't ischemic, it was more than edema. So that makes us wonder what was happening.
That's right.
She's getting better every day. So that's what I wanted to show you.
That's what I was gonna say. My thought is that maybe the opportunity here is for us as surgeons, as future leaders, to figure out, you know, the hemodynamic changes that happen all the way from the heart to the brain, you know, the way that changes both in the venous side and the arterial side, because I think that what happened here was just a lot of changes in a young, healthy patient. And as you can see, she's making an amazing recovery already. She's made an amazing recovery already. And I think a lot of them, as you said, was a lot of edema. First in the neck, went up to the brain, and she was just walking that fine line between life and death. And I just, I sensed the tremendous anxiety and angst that happened in this process. And you stay with her, multidisciplinary, everybody from the neurointerventional to the neurosurgeons to the neuro care, and everybody who you acknowledge to get this patient through this. It's just absolutely beautiful. But I think the opportunity is for us, hopefully in the future, to invent catheters that we can use. And I think Ravi's been involved with that. You probably comment, invent things that we can use in the venous side and the arterial side. So as you're doing those maneuvers in the operating room, you're beginning to understand, you know, what potential things we cannot do, where should we stop, should we stage it? Because those decisions could potentially be done intraoperatively if we knew the way in which we're changing the pathophysiology of these beasts, as I call it.
So to be honest, I want to make sure that you guys realize that this outcome could be the same with different strategy. Like, so don't beat yourself on the embolization, but that's what I think sometimes does help. So I don't think you can change many things answering those questions. The only one thing that I found that would be helpful, I didn't see, you guys have every technology, perfusion imaging. You can get a CT perfusion or MR perfusion in the post-op, especially on those phases where you have the swelling, you're not sure if this is hyperperfusion or so. But hyperperfusion can manifest with this kind of edema as well. And you can quantify it on a CT or MR perfusion. So you guide your pressure, you know, settings to lower your pressure settings and so forth. But I'm sure you guys were on it with technology. That's the one thing that could have been done. Otherwise, I won't beat myself for anything you guys have done. Great work. Those are challenging cases, and every one of us know those fires you're talking about in the last code, that everything is on fire. Yes, I like the script very much. AVMs are very difficult, and I don't know if we're going to have all these answers. There is a study enrolling a TOBAS trial, basically based in Canada by Raymond. And I'm enrolling in the trial personally for the registry arm. I'm not randomizing those patients because it's very hard for me to randomize based on what I know for AVM. I just, ethically, it's very hard for me to tell this patient, yes, you're going to be on this arm because the computer decided. But for the registry, I think we should all be recording what happens to those AVM patients. So one day we can look back and see why and try to answer some questions.
Yeah, I think it speaks that, well, you know, the problem here is we all know that we need more data. And we all know that that as you know, the problem is really complex. And unfortunately, complex problems take big numbers. And it's difficult to get big numbers with AVMs, and it's difficult because it's difficult to stratify AVMs into categories well enough to get the kind of data I think that we need, and that's what we've all been struggling with. The other thing that happens with the complications of AVMs are often manifested over decades, and the fact is that you really need to follow people for a long time to know whether intervention is going to be better than natural history. And the truth is, with funding cycles and other things, it's very difficult to get those kinds of studies done. We almost have to get, you know, consortium together. We have to get private money because federal money won't you know, government money won't follow you for long enough. But I think we can do it. But it's going to take a world effort. It's going to take an effort like you have in this room with people everywhere, because there aren't enough numbers in any one place to get these answers.
Even my partners agree with you, Dr. Miller. That's exactly what they were saying. Is these groups where you have people from around the world doing cases and asking 1 or 2 questions that you can monitor over time, and 1 or 2 devices that we together invent to be able to monitor these things. I think that's the future, and I think that's what I'm excited. The way that the technology, what happened over the last 2 years, getting us together like today, you know, is becoming and making these dreams a possibility and a reality. I apologize for rocking Apollo. They got super excited right here. They're like, we want to be part of these too.
Perfect, Dr. Quiñones. So any afterthoughts? I don't know, Dr. Gomez want to say something about this?
I think we have been discussing all the things that we want to discuss in this point, but it's okay because I can see how everybody was very excited with all the results and the course of the case. So it's just the thing that the importance of making decision the right moments. I think 1 hour, 1 minute can be the difference, even though it was too hard to make a decision about the compressive craniectomy. I think always as a neurosurgeons, we feel that the worst scenario, more in this case, was scheduled as a surgery and a treatment. We never think to get at this point. So, but at the end, and the history will the story. The important is the last
Happy
point,
ending.
the happy ending in this case. Dr. Hakim.
Yes, as I said, the decision to make the decompressive craniotomy, I think, changed the course of this patient, definitely. That's what I meant when I did the introduction. When Diego Gomez decides to do this, I think he saved the patient's life and the quality of life. Because probably the patient would have survived, but with the hemiplegia, I don't know. But I would like Juan Pablo to show the last picture, and Doug.
What you guys are doing in Colombia. All right, very good.
Thanks.
Thank you. Take care.
Very, very, very good case.
Have a great weekend.
One of the best we come across for education. Thank you.